good afternoon, and welcome to Infectious Disease Grand Rounds. There is no commercial support for today's program. The planners have disclosed no relevant financial relationships. Our speaker will disclose his relationships in just a minute. And if you're viewing online, please click on the link in the chat to sign in to the activity. If you have a question for the presenter, please hold until the Q&A segment at the end of the talk. And if you're attending virtually, you may enter your question into the Q&A chat. A link to the event survey will be shared at the end of the program. It is my pleasure to introduce Dr. Supriya Manapalli. She is our Medical Director of Infection Prevention and Control Department.
Thank you, Jennifer. Our speaker today is Dr. Adam Bressler. Thank you, Dr. Bressler, for agreeing to present as part of the ID Grand Rounds. He was born and raised in Atlanta, Georgia. He attended medical school at Medical College of Georgia, residency in internal medicine and pediatrics at Duke University. Dr. Bressler completed an infectious disease and medical microbiology fellowship at Emory University. He was a partner at Infectious Disease Specialist of Atlanta from 2005 to 2024, Medical Director, Clinical Microbiology Lab, Infection Prevention and Antimicrobial Stewardship at Emory Decatur Hospital, experienced in clinical research and Chief of Staff at Emory Decatur Hospital. Dr. Bressler is currently the Medical Director for NGPG Infectious Diseases Group and came to Northeast Georgia Physicians Group in April of 2024. He's married to his high school sweetheart with 3 kids aged 18, 21, and 23. He enjoys fishing, traveling, and soccer. Please join me in welcoming Dr. Bressler.
Thank you for that introduction, and thank you for attending. So we are going to talk today about the fungus among us. Fungus is near and dear to my heart, which not many people say, but I think it is something that impacts us clinically and in medicine, and that I think a lot of times there's a lot of questions about. So disclosure, I am with some speakers bureaus, none of which impact any of these discussions. So, I think when I think of fungal diagnostics, it really is perilous. It's sort of like Scylla and Charybdis trying to navigate between a rock and a hard place. The diagnostics for fungus are complicated. But having said that, we see a lot of patients with concern for fungal infection. And that's in part because we have a very complex medical and surgical patient population. We have a lot of relatively or significantly immunosuppressed patients. We have a lot of patients, I have learned here, with various forms of chronic lung disease. We also are at sort of what I'd call an endemic overlap in our geography, where we are here, and we're also the chicken capital of the country, all of which contributes to a lot of potential fungal infections. We're going to talk today really about the testing as opposed to the clinical aspects or treatments of these infections. And I'm going to tell you this, fungal diagnostics and taxonomy suck. I'm pretty sure that there is a plot among mycologists to keep it very arcane and mysterious to maintain their own relevance. The diagnostics are tricky. I say this from personal experience. I spent almost a year of my life trying to develop Aspergillus PCR with almost nothing to show for it. Other than it is the holiday season this time of year. I will tell you, my wife reminds me this time of year all of the time that there is no more holiday party more boring than a mycology holiday party. But I think the problem is that these tests, as well as the patients that we tend to utilize them on, are just variable. They're variable in their quality. The patient population is difficult. They're variable in their interpretation. And so it's very easy to misunderstand how to use a test or what to do with it. So we're going to try to go into some of these key infections and diagnostics, maybe come up with some ways of when to use one test or not to use it, and how to interpret it. So this is at least a partial list of the fungal diagnostics that we have available, orderable in Epic at NGHS. And as you can see, it's a pretty extensive menu with lots of different types of testing algorithms: culture, antibody, antigen, PCR, a lot of different organisms, different sample matrix. So it can be rather confusing on when and how to use all of these different tests. We're going to start off with what we call the beta-glucan assay, or BDG, most commonly known as the Fungitel, which is the brand or one of the brands of this kind of assay. This is probably the most common fungal assay that I've seen ordered here, and that's probably true of many institutions. The idea is that it measures beta-glucan, which is an antigen seen in fungal cell walls, and that it can therefore be used to help diagnose invasive fungal infection. Certain fungi, like zygomycetes or cryptococcus, don't have BDG in the cell wall, so it won't help you with those. As I mentioned, there's different assays out there, different brands. Fungitel is probably the most common in what we see. And even within the assays, they can be used different in terms of their cutoff or how they're interpreted and things like that. You can have false positives. Different bacteria, including strep pneumo, Pseudomonas, can cause false positives. Different medications like Zosyn or amoxiclav or albumin, dialysis membranes can all trigger false positives for this assay. It's been studied in a lot of different studies, a lot of different patient populations, and a lot of variable design cutoffs. So these studies are hard to sort of pigeonhole into one defining criteria. I mentioned the EORITC MSG. You'll see that over and over in these. Basically, that's the European Organization for Cancer Trial and the Mycosis Study Group criteria for diagnosing fungal infections. So these are widely accepted as the most standardized way to define a patient with an invasive fungal infection. And again, because of these variable assays, because of the variable patient populations, the different studies, it's very difficult to generalize or interpret the data for any one test. So this is looking at a meta-analysis in invasive fungal infections. I know we've all learned sort of the pitfalls of meta-analysis, and that's true. They have their problems. I think that when you have complicated, heterogeneous, dirty type of systems like fungal diagnostics, meta-analysis can be helpful to kind of give an overview to help smooth out some of the edges. So this is looking at what ended up being 23 studies out of an initial 3,000 screened that met their criteria for being appropriate studies in terms of patient population, diagnostic criteria, things like that. Even with those criteria, there's a lot of heterogeneity. These studies are all difficult to lump together. So this is looking at pooled data in some different subgroups. And I say beware of Bayes' theorem. We're going to talk a little bit about that too. When we learn about diagnostics, we often think about sensitivity and specificity and sort of think that that's the end-all, be-all of diagnostic testing. I think what's important to keep in mind, and essentially the gist of what Bayes' reasoning or Bayes' theorem gets at, is that in spite of whatever the inherent characteristics of a test are, its sensitivity, its specificity, what's very important in assessing how well a diagnostic test works in the real world is thinking about the underlying prevalence or pre-test probability. So a test or a condition that is extremely rare in a population, despite good sensitivity or specificity, may end up with inaccurate testing. By the same token, a condition that's very common in a population, even if you have good sensitivity or specificity, may end up with false negatives. And so just keep in mind that the pure inherent characteristics of the test itself are one thing. There's also how common is that condition or disease in the population you're studying. But in looking at this and looking at Fungitel and how it performed, or in the beta-glucan and how it performed in these tests, you kind of see across the board whether they're looking at proven invasive fungal infection, which is going to be your most sort of reliable and pure group of fungal infections, versus proven or probable, a little bit dirtier. Some of those patients may or may not in truth have fungal infection. Or the Fungitel Glucotel, which is the commercial assays that we mostly use, you see fairly similar moderate sensitivity and specificity. But again, the likelihood ratio incorporates what I was talking about with Bayes' theorem. Likelihood ratio incorporates your pretest probability or your prevalence. And then incorporating that, which again may be based on local knowledge, may be based on population studies, epidemiology, et cetera, it allows you to use that pretest probability along with the performance of the test, the sensitivity and the specificity, along with some math equations you can look up on ChatGPT, to come up with a post-test probability. So it really allows you to do some clinical decision-making with looking at, if I have my pretest probability, what I think the prevalence is, and now I have this result, either positive or negative, how does that then change how I assess the post-test probability? Does the patient actually have the condition? And I'll just tell you that for the most part, a positive likelihood ratio of about 10 or greater is a strong test, and a negative likelihood ratio of about 0.1 or less is a strong result. So although the sensitivity and specificity for these beta-glucan assays is decent, when you actually apply the likelihood ratios, what you see is they aren't actually as useful as you might hope or expect in really determining whether a patient has a condition based on the result of this test. That's kind of the gist of what that means. So in the previous analysis, we were looking at beta-glucan or Fungitel for invasive fungal infections other than pneumocystis. Pneumocystis jirovecii is sort of, over the years, the controversy has been, is it a fungus, is it a parasite? Well, it's a fungus. It has beta-glucan in its cell wall. And so therefore, the Fungitel or beta-glucan assay has been utilized sometimes in evaluating patients for PJP, or PCP as we used to call it. We see actually more and more PJP showing up in our non-HIV immunosuppressed population. We see less of it in our HIV population since the proliferation of antiretroviral therapy. But certainly what we know is there's a higher morbidity and mortality when there's a delayed diagnosis. And again, in these non-HIV populations, we may not be thinking about it as much. So this was another meta-analysis. It ended up looking at about 22 studies out of all that were screened. And they were looking at using the Fungitel or the beta-glucan assay for diagnosing pneumocystis pneumonia, in which a case was defined by a definitive either stain or PCR test. Most of these using the Fungitel assay, and it incorporated both HIV and non-HIV populations. So again, this is looking at the pooled data, but remember, it goes beyond just the sensitivity and specificity. Remember the Bayes theorem, remember the likelihood ratios, remember the pretest probability. But in the end, what we see is we see, again, fairly decent numbers in terms of sensitivity and specificity in both HIV and non-HIV populations. But when we look at the likelihood ratios, again, what we see is that the positive likelihood ratio, again, I threw out 10 as sort of a rough number. Neither of them are actually particularly that high. So a positive test does not confirm by any means that the patient truly has that condition. The negative likelihood ratio is, less than 0.1, I said is strong, is actually pretty strong, especially in the HIV populations. So a negative test can be quite helpful in convincing that the patient doesn't have pneumocystis. I think though the lesson from both of these is that despite fairly decent performance characteristics in terms of sensitivity and specificity, the positive likelihood ratio, in other words, after you have a positive Fungitel test, what is the likelihood that your patient has one of these conditions, is not actually all of that predictive. This is essentially what we call receiver-operator curves. I won't go too far into it, other than this is sort of the graphical equivalent of what we just talked about. So when you really want to look at your performance of a test and look at optimizing sensitivity, specificity, and likelihood ratios, these receiver-operator curves kind of tell you and can help you determine with cutoffs where your best place or utilization of this kind of test is. So the next test we're going to talk about is the galactomannan assay. We also see this used fairly frequently in different forms. For the most part, this test was designed for Aspergillus, or at least the galactomannan, Aspergillus galactomannan assay. Aspergillus is the most common mold we see in invasive fungal infections. And the traditional tools that we had for diagnosis were poorly either available, involving either invasive procedures, bronchoscopy, biopsy, or of low sensitivity or specificity, such as culture. We do know, again, that early diagnosis and treatment is critical for impacting morbidity for Aspergillus infections, but by the same token, avoiding unnecessary treatment is important because the drugs that we use for this can be toxic, there can be a lot of drug interactions, they can be expensive or hard to acquire. So you really want to find that sweet spot of not missing infections, but not over-treating non-infections. So the galactomannan is another cell wall component seen in Aspergillus as well as other fungi. It can also be cross-reactive with things. Besides fungi, it can be cross-reactive with fungal-derived products. I don't think we forget about this sometimes. Penicillin, and therefore penicillin derivatives, is a fungal product. It's produced by the penicillium mold. And so these can cause cross-reactivity with galactomannan assays. We measure it by an ELISA, which is just a type of antigen antibody capture assay, and it can be done on both serum and bronchoalveolar lavage fluid. Again, very, very heterogeneous in terms of the way the assay is used, the testing strategies, how it's interpreted, the cutoff points, or what we call the ODI. In other words, how positive does a positive have to be? All of these things have a lot of variability, making interpretation very difficult. So again, I'm going to resort to meta-analysis for these because it helps kind of smooth out some of the data. This is the Cochrane review, which is a good place to kind of look at these kind of issues. And this was looking at serum galactomannan in immunocompromised patients. Again, it uses that EORITC MSG criteria that we mentioned. And out of all of the articles they screened, they ended up finding 54 that met their criteria for analysis, of which 50 had published ODIs or cutoff values allowing some quantitative analysis. And again, very heterogeneous in terms of the type of patients, the testing strategy. The prevalence of disease was very diverse, ranging from 0.8 to 44%, so really all over the map. These are some busy slides, but again, what they tend to do is just kind of highlight that in a diagnostic test, it depends on how you use it, how you interpret it. So this is looking at the cutoff values. So again, if you use a cutoff of 0.5, in other words, sort of positive, versus 1.5, it has to be more positive. As you might expect, the higher the cutoff, the lower your sensitivity goes. It's harder to find a true positive, but the better your specificity gets. This is looking at some other data. This is looking at how was the case ultimately defined. Was it looking at proven and probable cases, or just proven cases, or proven or probable or possible cases? Again, which is going to impact kind of how dirty your case definition is, which will impact the performance of the test. But the bottom line is that you can see that the sensitivity is mediocre at best across a lot of these, and the specificity is variable. I think this is a pretty real-world way of looking at some of this, and I think the authors are trying to convey that, what do all these numbers mean? It basically means that depending on what kind of cutoff value you're using, if you had a hypothetical population of 100 patients with invasive aspergillosis, you might end up actually missing quite a few with a high cutoff value, or overdiagnosing or overtreating quite a few with a low cutoff value. And that's the gist of what they're trying to get at. So what about looking at galactomannan and BAL fluid? I think the idea is that, well, why not go right to the source? We're often looking for lungs as the source of infection. Why not go to the lungs and see how the assay performs in the lungs, as opposed to trying to capture antigen that gets released into the bloodstream, into serum, which makes sense. And there is quite a bit of studies and data that's looking at this. Again, out of all of the studies that meet the proper criteria, only a few are really eligible or appropriate for analysis. I think the thing to think about, though, is although BAL fluid is, so to speak, getting closer to the source, it's introducing some complications or bias, right? It's very easy to get serum. We get blood every day, all day on patients in the hospital. It's not so easy to get BAL fluid, right? It's an invasive procedure. And so, in general, the people who are going to get BALs are people who may have other issues or have already had suggestive testing. They have maybe abnormal CT scans, or they have ongoing clinical findings, or maybe they've already had a serum galactomannan that's positive. So there's going to be some bias in that the people going for BAL in the first place might have different versions of bias as to why they got there, and therefore your findings and how to interpret BAL fluid galactomannan can be altered. And I think the authors stress the importance of keeping that in mind. So again, this is just looking at different types of subgroup analysis. And again, what you see is, depending on the cutoff, is it a low cutoff, making it more sensitive, or a high cutoff, making it more specific? Did they think about bias in the different studies? Did they incorporate bias? Incorporation bias means when the test in question is part of the definition, right? So in some of these studies, the positive galactomannan was what they were looking at or assessing, but then the result became part of the definition for a case. Obviously, that's going to introduce bias. Were they prospective studies, which tend to be more rigorous and therefore, maybe more specific, versus retrospective, where you're already going to have some predefined definitions that might impact your specificity. So all of these kind of things can have very significant impacts on the performance of the test. So it's never simple. Again, this is looking at that sort of hypothetical population with a given prevalence of 12%, sort of based on what they see in a lot of these studies, is a prevalence of maybe 10 to 15%. And again, depending on your cutoff value or some of these other parameters, you might miss a decent number of patients, and just as importantly, you might overdiagnose or overtreat a significant number of patients. So what about Aspergillus PCR, right? Basically since COVID. Prior to that, it was, I think something we thought about a lot. Since COVID, I think everybody thinks about PCR. Everybody knows what PCR is. Everybody sort of thinks of PCR as the be-all, end-all for diagnostic testing. So there has been PCR for Aspergillus developed, despite my 1 year of failure in contributing to that. Other people have come along and been able to come up with some reasonable assays. And so there is some data looking at serum and BAL PCR for Aspergillus. So again, same kind of thing, Cochrane review, looking at multiple test criteria and trying to get at the best evidence available. Very heterogeneous populations, very heterogeneous testing algorithms, all of these kind of things that can impact your performance. Do you require one positive or two positives? All these kind of things make the interpretation difficult. This is just looking at some summary data though, and again, the idea is that you will sacrifice sensitivity for specificity depending on how you define it. Is a single positive enough to be defined a case, or does it require two? Either way, despite marginal sensitivity, moderate specificity, when you look at these likelihood ratios, which again, taking into account the prevalence, the pretest probability, you see the utility of these tests, especially your negative likelihood ratio, your ability to rule out is pretty compromised, and even your positive with a single result is not really giving you that much insight as to whether the patient likely has the condition. So again, this is that sort of breakdown into real world language. In a given population of 100 patients, of which the prevalence was set at 16%, you're gonna miss some cases, and more importantly, you're gonna incorrectly diagnose a lot of cases. If you increase the positivity to 2 positive tests, your sensitivity will go down, but your specificity will go up. So this is looking at the PCR in BAL fluid. Again, maybe you get right to the source, serum's too, less specific, go right to the source, get into the lungs. Same kind of biases that we think about. People who are going for bronchoscopy likely already have something going on in the first place, CT scan that's abnormal, et cetera. I think one of the important things about this meta-analysis that I wanted to mention is that this was not looking at just hematological malignancy or transplant patients. This was looking at other what they call at-risk patients. So patients with COPD or autoimmune disease or steroids or things like that, which is really the patient population that we see more often when we're thinking about possible fungal or Aspergillus pneumonia. So those patients were included in this meta-analysis. So this is looking at PCR, or Aspergillus PCR on BAL fluid. And this is some subgroup analysis. First looking at the hematopoietic stem cell population, and then these sort of others, which again is the group that we really more frequently are dealing with. And again, your sensitivity and specificity are actually better in your other population, the kind of patients that we're seeing. And your likelihood ratio, which again is really a more useful sort of measure of how to use the test, shows a little bit better performance. So at least in this study, or in this meta-analysis, in this population, there was some value in Aspergillus PCR on BAL fluid, especially in the kind of patient population that we think about. So, the question is, well, why would it perform better in these non-hematopoietic malignancy or transplant populations, right? As you'd think that would be the population where it would be best utilized and best described. And I think there's some decent explanations to think about. So one, there might be patient factors, level of immunosuppression, other things going on. There might be selection bias. The people who are going to BAL in the first place might be different depending on how stable or unstable they are, who can get to a BAL, who has thrombocytopenia and things like that that could impact it. I think the most important one probably to think about is antifungal prophylaxis. So in these hematological malignancy patients, in these transplant patients, a lot of them are started fairly early on prophylaxis, and that prophylaxis is going to obviously increase or decrease the yield of your fungal PCR. This is just one study looking at BAL fluid, galactomannan, and PCR in chronic pulmonary aspergillosis. So again, this is a lot of maybe what we see when they're not acutely ill, neutropenic, invasive aspergillus pneumonia. It's maybe something more like fungal ball, aspergilloma, more chronic nodular aspergillus pneumonia, some of the conditions that we see a lot in our patient population. And this is looking at galactomannan and PCR, aspergillus PCR in BAL fluid. Again, a lot of the concerns that we've already mentioned would apply. And at least in this study, what they found is really fairly poor sensitivity and specificity of any of those assays. So in this population of chronic pulmonary or suspected chronic pulmonary aspergillosis, these assays weren't as useful. Next, we're going to talk about cryptococcal antigen testing. I think we all are very familiar with cryptococcal disease. We see a lot of it here. Chicken capital of the country contributes to that. And this is sort of just a summary of a lot of data from all over the place, personal experience. I'm not really citing any particular study. I'm just going to try to convey some themes about cryptococcal diagnostics. And I'll start by saying cryptococcal antigen testing is sensitive and specific in its own right. The tests themselves are good tests. But having said that, it goes beyond the inherent capabilities of the test. Again, thinking about how we get to that test. What kind of specimen is it? How is the test being performed? Who's doing the test? Who's interpreting the test? What is the prevalence in the population? All those things can impact the kind of interpretation that you get with these. And you still may end up with false negatives or false positives despite good inherent characteristics of the assay. So we're going to talk about CSF first. And I think, the blanket statement is that in any patient suspected of having cryptococcal meningitis, or in any immunocompromised patient suspected of having any kind of meningitis, cryptococcal antigen testing is a good test to do, and I would recommend it. And any positive needs to be taken seriously, and probably, unless proven otherwise with some other explanation, probably be considered indicative of CNS disease or cryptococcal meningitis. In terms of, do we have to retest them? Do you have to monitor them? In a patient who had a normal opening pressure to start with, and has a good response to treatment, you don't necessarily have to repeat lumbar puncture and get further cryptococcal antigen testing. The titers or the antigen can persist far beyond sterilization. So we may treat these patients and the CSF may sterilize, but the antigen can remain positive for a long time after that. Having said that, if you are getting repeat titers or testing because perhaps they're not responding to treatment clinically, or because they had a high opening pressure and there's concerns for intracranial pressure, the CSF antigen titer can potentially be a marker for response to treatment. And so serial testing, looking at that titer, can potentially give you some clue as to whether they're responding appropriately. Having said that, other things can matter. Obstructive hydrocephalus, other components might be impacting. What about serum testing? We do a lot of cryptococcal serum testing, and the question is, what does that mean and what to do with it? What I would say is that in someone who's never been diagnosed or worked up or treated for cryptococcal disease, a positive serum test could mean something, and it has to be taken seriously, and you have to decide what to do next with it. If they're immunocompromised, significantly immunocompromised, AIDS, high-dose immunosuppressive therapy, et cetera, it probably should prompt CSF testing, or if CSF testing is not available, for whatever reason they can't undergo lumbar puncture, probably assume CNS involvement. If they are less immunocompromised or non-immunocompromised, a serum cryptococcal antigen test might mean something. It might mean pulmonary or localized disease. It still could mean disseminated or central nervous system disease. It kind of just depends on their overall situation, their clinical presentation, their risk factors, and what I would sort of say is, take all that into account. The titers can matter. If you have a titer of 1 to 8 or greater, it's probably more likely to be indicative of active disease of some kind, and that might inform your next steps in terms of workup or treatment. If it's less than 1 to 8, it's harder to know. There can be false positives. but it also can be seen with true disseminated or CNS disease. So I think you have to kind of look at your patient, look at their presentation, look at your assessment of their risk factors, and decide. You might decide to do repeat testing, or you might decide to do serial testing, or you might decide to monitor with or without a lumbar puncture, or even with or without treatment. And we've seen all of these scenarios kind of come across in our patients. And I would recommend, again, if you're not sure, ask infectious disease. We're happy to get involved in these situations because they can be tricky. What I will say is that the serum titers are of really no value in assessing response to treatment. Whether it goes up or down doesn't mean much. We don't do test of cure to see if it goes away. I would not use it in that respect. So this is something that was actually new to me when I came to Northeast Georgia. I had not experienced this in my previous practice. This is ROSE, a ROSE by any other name. So ROSE is rapid on-site evaluation. And basically the idea is that at the time of the procedure, bronchoscopy, biopsy, et cetera, they do sort of a rapid on-site touch prep of the sample. And they do some staining, and they look at it. The technologist looks at it right there in the microscope and looks for fungal forms as the procedure is being done. And this has been shown in some studies to be useful for diagnosing invasive fungal disease in pulmonary samples or other tissue samples. So in thinking about where that might be advantageous, obviously immediate results, right? You know right away, in real time, what might be going on in the lung, and that might impact your further workup or treatment. It might tell you something about your sample collection. Did you get a good sample, right? One of the ways that they assess the adequacy of their samples is by doing some of this immediate look at the bedside to see, did they get cellular material? Do they have to go get another biopsy, et cetera? So this might help you with that. And then if it does convince you to go ahead and start treatment appropriately, it obviously can be effective for clinical impact, length of stay, all of these kind of things. Having said that, there are some problems or limitations with this test, mainly that it's very operator dependent, right? It depends on the sample. Was it the right sample? Was it obtained correctly? How was the processing of the sample? And probably most importantly, how was the expertise of the person reading the sample? Do they know what they're looking at in terms of really identifying fungal elements? And then its resources. Not every institution has the capabilities to do this. So I'm just going to go back quickly. A rose by any other name would smell as a mold. Does anyone know the reference for that? The real quote is, a rose by any other name would smell as a rose. It's from Romeo and Juliet. But I just couldn't resist because it just fits so right. So in thinking about, well, how does this rose work? Is there any real data telling us how effective it is in diagnosing fungal infections? There's not a lot of data out there, but there are some studies. In this one study, it had a fairly decent sensitivity, about 80-something% in detecting filamentous fungi, pretty comparable histopathology, and a pretty good specificity. Obviously, the advantage is that it was quick, right? The results are obtained within minutes, basically at the bedside as the procedure is being done, which is going to be quicker than your other assays, including pathology, culture, and other tests. And at least in this study, it impacted their treatment and helped initiate antifungal therapy in about 3/4 of the patients. So it had some value here. We're now going to talk about histoplasmosis and blastomycosis. So these are some of what we call the dimorphic fungi. And what that means is that they can be a mold in the environment, in the soil or wherever they're growing, but a yeast when they're in the body. And it's important because we talked about that overlapping geographic range. They're both endemic to Georgia and the Southeast. So while we think about crypto and the chicken farms, and we might think about histo as being sort of in the Southeast, including Georgia, we also have blastomycosis here. In thinking about some of the clinical presentations, there is a lot of overlap. There are some subtle differences, but certainly probably the most common presentation is asymptomatic. A lot of people will acquire this and never know they had it, or have a minor illness that they never really seek attention for. Acute pulmonary illness or chronic pulmonary illness is probably one of the more common things we think about. For histoplasmosis, there's what's called mediastinal, which is essentially sort of a fibrosing or scarring inflammatory response to pulmonary disease. Cutaneous disease we can see in both skin manifestations. Disseminated or CNS disease is something that's sort of rare, but one of the dreaded complications. And then with blasto, there's some other rare findings like genitourinary blastomycosis or osteoarticular. So in terms of the diagnostics for histo or blasto, they're a little bit overlapping. And the idea is that antigen detection is probably the most valuable tool we have in our arsenal for these kind of fungi. So basically, these are looking for fungal antigen shed either into the urine or the serum. For histoplasmosis, the urine antigen has been sort of our mainstay and has pretty good sensitivity and specificity in acute disease, disseminated disease, severe forms of disease. In more chronic forms, it's not as useful. They're, again, specific, but there can be cross-reactivity with other fungal antigens, including blastomycosis. Blastomycosis, again, I think we don't think about it as much, but it does have urine antigen testing. When I showed you that menu of all of the tests available, like histourine antigen testing, there's blastourine antigen testing. And in fact, there's a lot of, again, overlap. They can be cross-reactive. And so we've had some cases where, suspicion of one, probably histoplasmosis because we think of it more commonly, can actually fool you and it turns out to be blastomycosis because there is this cross-reactivity. In terms of antibody or serological testing for histo, there's different types of antibodies, either complement fixation or immunodiffusion. And, the sensitivity and specificity can vary. Tends to be pretty decent, except when we think about specificity, there's the idea of false positives, but then there's the idea that it's not a false positive. The antibody really is there, but what does it mean? So in areas where it's endemic, you may have persistent antibodies that aren't indicative of active disease. So I think the serology or antibody testing, especially in terms of thinking about positive tests, is a little bit harder to interpret because of this. Also, the antibody production can take weeks, so your specificity can be impacted by seropositivity with inactive disease. Your sensitivity can be impacted by timing. If it's early on in disease, you may not have formed an appropriate antibody response. For blastomycosis, the antibody testing, the serological testing is just not very good and probably not very useful for most cases. Culture, obviously culture is sort of the gold standard for anything, and if we're able to culture the organism, it's useful. Really it depends on being able to get the right specimens. So if getting invasive specimens may not be feasible. The growth is slow. It can take weeks for these fungal organisms to grow. It requires special biosafety level labs to be able to grow these organisms. So it's not always very easy, but I would always encourage the attempt to try to get the sample. Sensitivity for histopathology, again, if you get the sample, if you get the biopsy, and the pathologist can look at it and interpret the staining, it can be very useful. It can be both fairly sensitive and certainly very specific. It's usually the acquisition of the sample or the tissue that's the hard part. There is molecular methods out there. There is PCR for histo and blasto. We do have it available in our test menu. Again, that's going to be mostly for tissue samples. So if you get the lung specimen or the tissue sample, it might be a test to use, but it's not going to be readily available and not something we could use on serum or urine. So this is sort of the algorithm that the CDC puts out. And this is probably one of the more common scenarios where we're thinking about histo or blasto. And again, since I've been here, we've had several patients that really kind of fit this type of algorithm, and we kind of ended up going down these roads. So you're thinking about pulmonary disease, patients with sort of pneumonia that's not responding to antibiotics, or maybe sort of a nodular pneumonia, or pneumonia with risk factors, whether it be exposure to, environmental situations, soil, leaves, gutters in a patient we saw, bird or bat guano, things like that. Those are the kind of patients where you might be thinking about histoplasmosis or blastomycosis. And the initial test really to start with is probably the urine antigen for both. You might consider your antibody testing for histoplasmosis also. If the antigen is positive, you could feel confident that that's the active disease and appropriate diagnosis. If it's negative, it may be that you consider alternative diagnosis, but if you still have a high suspicion based on the clinical or the epidemiological factors, because the testing is not perfect, you might retest. and then decide, or, certainly infectious disease consultation. Again, these are the things to consider because the testing is insensitive enough that you can't rule out disease with a single test. So we don't think about coccidioides as much. This is the other endemic fungus, dimorphic fungus, that is associated with what we call valley fever and other forms of disease. This is what's typically associated with the San Joaquin Valley out west, the desert, Arizona, New Mexico, areas like that. And it can be associated with different presentations, again, asymptomatic pulmonary disease, disseminated or CNS disease. And unlike histo and blasto, where antigen is the mainstay of treatment, for coccidioides, antibody or serologic testing is the mainstay of treatment. And there's different types of antibodies, EIA, immunodiffusion, complement, all of which have some relative strengths and weaknesses. EIA tends to be easy with decent performance characteristics. Immunodiffusion tends to be harder. There's less labs that do it, although it can be more specific. Complement fixation is sometimes useful in that the level of the titer can suggest the activity of the disease versus more just previous exposure. Typically what we have here is it's a send-off test with a reflex. So it's a screening antibody, and then further, more specific immunodiffusion or complement fixation antibodies are done for positives. Obviously, again, culture is the gold standard, but is limited by the ability to get the right samples. It can be low in sensitivity, although highly specific, and again, requires BSL-3 labs to actually culture and grow the fungus because of the concern for laboratory acquisition. Antigen testing is available in certain situations, but is not very well studied or well defined. Histopathology is useful if you can see it, if you have lung tissue, for example, and the pathologist can identify the spherules. Remember, those are sort of like those barrels filled with little spores that are characteristic of coccidioides. If you can see it, it's helpful, but sensitivity may not be great, and getting the samples may not always be feasible. There are molecular methods such as PCR that have been developed, but again, they're not standardized or readily available in many labs. This is just sort of looking at a table of the different types of assays for coccidioides. I won't dwell too much on it, again, other than suggesting that antibody testing, serological testing, is our mainstay of treatment, but even the performance characteristics of this aren't great, especially in terms of sensitivity. So I'm going to pivot now to kind of trying to synthesize all of these things we just talked about, because it was a lot of words and a lot of numbers, and I think I've actually bored myself again. So don't go to the mycology holiday party. Don't show up to the mycology lecture during holiday time. But no, I think the real key is, what can we use all of this for? Day to day when we're seeing patients, what am I really trying to tell you, right? Why did I bother to, just go through all of this? And I think these are some of the lessons I'd want to impart in terms of, okay, what does this all mean when we're seeing our patients in Northeast Georgia hospitals, what to do? So, tests that we should be using. Probably the most common and relevant test that we should be using in fungal diagnostics at our hospital is routine blood culture. Candidemia, or candida infection, is going to be by far our most common fungal disease, and it's readily detected with a standard blood culture. Nothing else has to be done. Fungal blood cultures should be used only for very specific situations. We don't need them to find candida. If you're looking for disseminated histoplasmosis, you can grow it in a fungal blood culture. Maybe some other rare situations, again, maybe an unusual FUO or something like that where some of these endemic fungal infections are coming to mind, might be something to think about. What about Fungitel? Probably the most common assay we see used. Even though it's not what it was originally designed for, and probably not how I see it used very frequently, I do think suspected pneumocystis pneumonia is the place for us to be using Fungitel. I would never argue with that, and if we don't think we can get a respiratory sample, I would use it myself in that way. Histoblastourine antigen. I think we're pretty familiar with that, and I think that's, again, probably still our best way to be looking for histo and blastos with urine antigen, recognizing some of the caveats. CSF cryptococcal antigen. Again, I think this is a test that if you were looking for cryptococcal meningitis, or if you're evaluating for meningitis in an immunocompromised patient, always get the CSF cryptococcal antigen test. It's easy, it's quick, it performs well, and it should be something that we use in our arsenal. Coccidioides serologies, if you are suspecting coccidioides, serologies or antibodies are the way to go. They're not perfect, but they're the best we have. I would just make sure that the patient has a risk factor, which, anything west of Texas. I'll tell a very quick story. I had this patient come to me in my previous practice. She came with a litany of complaints and rashes and coughs and all sorts of stuff. So the first visit, all I could handle was her rash. I couldn't really hear her, Rash got away. Next time she came back, rash was gone, but she was still having kind of cough and mild respiratory symptoms. She lived in Georgia and had, a bunch of leaves and yard work, and had been outside and taking tarps and covers off of logs and doing all sorts of things, exposing herself to dust and dirt and leaves. And she was, one of these things where a little bit of knowledge is dangerous. She was a knowledgeable patient, was not a medical provider, but had been in the medical world enough to know, and so was, really asking, what if I have a fungal infection? I'm like, okay, let's look for a fungal infection. As we're sort of getting through this workup process, she ended up being seen again before we had kind of completed all of this. She had then popped up with a skin nodule, or a couple of skin nodules. And at this point, I was like, wow, this is really interesting. She has skin nodules. By this point, we'd had a CT scan showing some pulmonary nodules. I'm like, maybe you really do have a fungal infection. And as we talked about, when we think of cutaneous disease and these endemic fungal infections, any of them can do it, but blastomycosis very much comes to mind. She'd had sort of the exposure to leaves and yard waste and all kinds of things like that, and had been only mildly ill. So we ended up getting, I biopsied multiple skin nodules. She saw pulmonary for the lung nodule and ended up getting a biopsy of the lung nodule. And sure enough, they all came back indicative of, what do you think? Blastomycosis. She had coccidioides. And so through dumb luck, we got the right answer. And through her little bit of knowledge being dangerous, she pushed us to get the right answer. So to speak, but not what we had expected. So when I called her with these results, I said, any chance you've been out west? Or said, oh yeah, about a month before all this happened, I was at a conference in Tucson. So again, always think about the exposure history. So back to tests that I think we should be doing. Bronchoscopy and BAL. So this is one that I think, I think I had certainly some questions about what do I do with this. We get a lot of patients where this might have been part of the workup, and I have trouble sometimes deciding what to make of it. In my opinion, if we're getting the bronchoscopy or the BAL or one of these type of procedures, and we're looking for fungal pneumonia, whether it be invasive fungal pneumonia or one of the chronic pulmonary aspergillosis syndromes, if they want to do the rows, I'd sort of say at this point, why not? It's quick, it's easy, it might give you some preliminary information. And so why not get it? Just keeping in mind, though, that if there is a concern for a positive, it makes sense to consult with pulmonary and infectious disease and pathology and really get a sense of what they're looking at. So in my N of one patient who had this done since I've been here, where there was a suspicion of seeing fungal organisms at the time that this rose was performed, when we reviewed the specimens with the pathologist and myself, we actually found nothing. It was a false positive. But I think it's rapid and relatively easy availability makes it worth something trying. I think fungal culture is worth getting, right? The gold standard is worth getting, recognizing that it might be a long turnaround time to get any kind of result. What about tests we should not be using? I think this is sometimes the more important lesson. We do a lot of tests, and people are used to thinking about antimicrobial stewardship. I think there's going to be a lot more talk about diagnostic stewardship. So what are some tests we shouldn't be doing? So I mentioned Fungitel for PJP is worth doing. I think Fungitel for anything other than PJP is probably not worth doing. I think the performance characteristics that we looked at and our patient population, which again does not tend to be as much of the hematological malignancy or transplant population, really doesn't justify its use. And I'm going to show you a little data that confirms some of that. But I think it's probably not a test that we necessarily need to be doing much of for most of our patients. Again, there might be some exceptions, patients who we have with prolonged neutropenia, et cetera. But the serum galactomannan and the serum aspergillus PCR, again, for the same reasons, thinking about the performance characteristics that we looked at, the likelihood ratios when you consider the prevalence being quite low, I don't think it makes sense for our patient population. We probably shouldn't be ordering many of these. Fungal blood cultures, again, I see a lot of fungal blood cultures ordered, most of which are probably unnecessary, because in most of those cases, if we're even thinking about fungus, it's probably candida, and the fungal blood culture is not needed. I'd say one of the more common places we see this in is what I'll call the sort of nosocomial fever, or the ICU fever. Again, don't need fungal blood cultures to look into that. In those cases, most of what we're concerned about is candidemia. We can get that from our regular blood culture. I've sort of been hyping cultures, right? Why not get the culture? Why not get the gold standard, recognizing its limitations? And for the most part, that's true. I will say the one place where we sometimes see fungal cultures where we may not need to is fungal cultures on all of the toe wounds, foot wounds, leg ulcers, tissues, bones, abscesses, and all of these kind of things where fungus is really not high on our list of suspicious organisms. Again, there's always exceptions, maybe prolonged wounds, heavily treated wounds, immunosuppressed. But for the most part, we probably don't need to be getting fungal cultures on what seems to be a likely acute bacterial type of wound or tissue or fluid. I was just mentioning the Fungitel. This was our experience for most of 2024 anyhow. The blue is the positive Fungitel assay, the pink is the negative. And what you can see here is that sort of across the board, our positivity rate is about 30-something%. Now again, when we think about some of those studies that we looked at, which are probably really even enriched for higher prevalence of invasive fungal disease based on the patient, remember we were seeing prevalences of maybe 11%, 16%, something like that. In our population, I'd venture to say there is no way 30% of our Fungitel should be positive. So again, I think we're seeing a lot of false positives. It's not getting us closer to what we really need to be looking for, and probably something that can be looked at as to how we use it. All right, so what about the maybes, right? There's some things that we should do, some things that probably we shouldn't do. I think there are some things that I'm on the fence on. So when we think about the BAL fluid test, the galactomannan or PCR on the BAL fluid, on the one hand, you're getting a little bit closer to the presumed source, and so you might have some of these improved performance characteristics of the test. Our patient population tends to be maybe more of these chronic pulmonary aspergillosis or not as immunosuppressed patients where you might have some better performance. So I do think there's some argument that it could make sense in those situations. I think where I fall on it is, to me, the galactomannan still is too nonspecific. It's cross-reactive with other fungi. It's cross-reactive with medications. How many of our patients are on Zosyn or other penicillins or dialysis with dialysis membranes, or a lot of them? And so I think you're introducing a lot of potential confounding data to use the galactomannan. I think the PCR is probably more valuable, although it may be non-specific in that it might detect colonization per se as opposed to disease. That's a determination you can make clinically. It's at least specific in terms of showing what it's meant to show. I think for serologies, I think for chronic pulmonary aspergillosis, whether it be bronchopulmonary or one of these kind of things, serologies are still part of the workup, but probably not so useful for acute aspergillus disease. I think for histoblasto, if your antigens are negative, it might be useful to further work up suspicious histo disease, not so useful for blasto disease. The sensitivity and specificity are just too low. And the serum cryptococcal antigen we talked about is a little controversial. It's probably never wrong for checking it the first time or for looking into an immunocompromised patient. If it's a non-immunocompromised patient with questionable localized pulmonary disease, it may be harder to interpret, and certainly not for monitoring disease activity or test of cure. All right, so this is the final slide. I don't know if any of you noticed the formatting of the slide. This was one of the stock formats that was available in PowerPoint. But I chose it for a reason. So you see these sort of here. To To me, these have a resemblance to certain fungal organisms. And, you know, there's maybe a couple of right answers here, a couple of acceptable answers that I'll take. All right, who has an idea of what fungal organisms this stock PowerPoint slide is a reminder of? This is actually Blastomyces dermatitidis. We talked about that. And in its mold form and culture, this is its appearance. The second one is one that we did not talk about really at all with any of these diagnostics. This is Mucor species. So that's my fungal trivia for the day, and that's it. Thank you.
Thank you so much, Dr. Bressler. Does anybody have any questions or comments for Dr. Bressler? Just raise your hand and I'll bring the microphone over to you. Sure, yes.
Thank you, Dr. Bressler. I think this is such a need for diagnostic stewardship with fungal diagnostics. And I see our lab colleagues. Do we know how much we spend per year on fungitel assay? Yeah, it's definitely, I think, as a follow-up from this talk, I think we should come up with some recommendations through the Diagnostic Stewardship Committee and present it to, at least start with our Palm Critical Care colleagues, which is where a lot of these tests get ordered, and then expand to the other areas.
I did not. It was a surprise to me. I didn't know that we had these lung infections due to being the chicken capital. Do you always test anyone who automatically comes in and says they work there, or they have to be having symptoms?
Yeah, so you mean if they work in the chicken industry but are coming in for something else? Is that what you mean?
Like, is it just an automatic?
No, and that's why I would
high
definitely
is
not
this
make it an
risk?
automatic, right? I think it's, you know, and it is tricky because there is this idea that a positive serum antigen is never, quote, normal. And yet we know there are false positives, and what it means is hard to say. You know, I think on the one hand, if someone does work in the industry and they have at least potential concern for a compatible syndrome, an unexplained pulmonary process or pneumonia or nodule, I think it's a reasonable place to start, recognizing that the result is not always the final answer. If they have, you know, symptoms that just aren't really suspicious for Cryptococcus, you know, they're coming in for whatever, a myocardial infarction or who knows what, I don't think sort of routine cryptococcal testing for people in the industry is necessary by any means.
Or is the industry, I'm sure they have to be very aware and do the preventative care. I mean, how common knowledge is this? Because like I said, I've lived here my whole life and never knew.
Yeah, you know, I think it's a good question. I don't know how much awareness there is in the industry. And I don't know that I could even speak to, I mean, you're sort of thinking of in terms of just sort of safety and protection.
Preventative care.
You know, mask or who knows, yeah, I don't know. And I will say, while, you know, the working in the industry is pretty ubiquitous, right? You know, if you've lived in Gainesville your whole life, you've been exposed to Cryptococcus in the dirt. If you've lived in most parts of Georgia, you've been exposed. So, you know, it's ubiquitous. It's just, it's a relative degree of exposure.
And more for immunocompromised, I guess, would be more at
To
risk.
develop disease more immunocompromised, right? There are probably, you know, many people that have been exposed, inhaled Cryptococcus into their bodies, and never really developed significant clinical problems from it.
So we did have some mutters back here of Mucor, so it wasn't lost on everything.
Well, you and I looked at one together, and so I was back here saying Mucor, but I'm shy.
So one of the things I noticed is with our, and that we see in the laboratory a lot, is the cryptococcal antigen test when compared to the PCR that we do as part of that meningitis encephalitis panel. And frequently we will see, I guess, frequently in the sense that we do come across it, yeah, on occasion, not necessarily with all of the ME panels, but when we do see that, oftentimes you will have a more sensitive test by that antigen test. So it's a little bit counterintuitive that the antigen will be picked up when the PCR is negative, but sometimes that's something to consider, especially with the different types of tests and their limitations. With cryptococcal antigen, that tends to be, in some cases, more sensitive even than that PCR.
Yeah, I think that's a great point. And also, to be honest, gets at one of the, you know, that theme of stewardship. You know, I think because of its utility as a test, but also because it's cheap, it's easy, it's in-house. I think I tried to make a point that if you're thinking about a CSF cryptococcal antigen, do it. do them all the time. I got no problem with as many CSF cryptococcal antigens as we want to do. I think what you're getting at, though, so you're speaking about the CSF panel, the sort of BioFire or similar type CSF molecular panel. I think that is another test that is probably sometimes either overused or maybe not used in the most effective or efficient manner. I think everybody has the idea that PCR is going to be the way to find all of these things, and it's not always. Or sometimes multiplex PCR, looking at a bunch of different targets, may not be the way to do it. I think more importantly, it probably doesn't make a lot of sense to do PCR on every CSF up front until you have a little more information. What do you know about the CSF parameters in terms of, the cell counts and the proteins or the glucose or other tests or the cryptococcal antigen that may give you an answer right away that you therefore don't have to go searching for these other things, or your patient and whether they're immunosuppressed or not. So I agree. I think, the general idea is that the CSF molecular panel is probably something that we should think about when and how we use it, and think about how to do diagnostic stewardship with it, as opposed to just kind of adding it on when we're looking for all these other things.
Anything else? I think we are at time. Thank you so much, Dr. Bressler, for joining us today.